Welcome to JAMA Plus AI Conversations. I'm Roy Perlis, Editor-in-Chief of JAMA Plus AI.
And I'm Yulin Hswen, Associate Editor of JAMA and JAMA Plus AI. And we're your hosts today for a very special episode. It's the 1-year anniversary of JAMA Plus AI. So it seemed like a good time to look back at the year and look forward to the coming year.
So we asked Claude and ChatGPT. No, we did not do that. We did it the old-fashioned way. We actually read the articles. And what we want to share with you over the next little bit are some of the articles that we thought were the most interesting over this past year. So, Yulin, you're first. What's your first pick?
So I really like this study by Rippart in JAMA Neurology. They looked at a condition called focal cortical dysplasia, FCD, and it's this brain abnormality that often causes hard to treat epilepsy. And it can be difficult to spot on regular MRI scans. So patients can go underdiagnosed or wait for years. And so what they did is they built this new artificial intelligence tool called a graph neural network. It's basically a model that looks at how the different parts of the brain surfaces connect. And it was interesting because the results showed that the AI found over 60% of brain lesions that radiologists actually had missed. And they gave clear reports. The AI tool gave clear reports about where the problem was. And so, for patients, you could actually get more accurate detection of FCD and earlier. And so, this AI tool could really provide kind of a second set of eyes. And I guess what I really liked about this was that, the AI tool, it didn't just look at brain images, kind of pixel by pixel. And me, I love image analysis, and I think it's the future, but they actually hybrided it with using this neural network, which kind of mapped the brain and was able to kind of connect regions. So it was especially good at spotting kind of tricky areas and hidden abnormalities. So I thought that was a really interesting study.
So was this one of those that is sort of AI augmented radiologist, where the radiologist then has to look at the image and try to figure out what the model is picking out? Or is this the model sort of runs soup to nuts and gives you the answer?
The model ran soup to nuts. And so they did a comparison with radiologists, and they just found it to be, more effective at identifying brain lesions that radiologists actually missed. But I mean, in general, I don't think that AI should be, replacing radiologists, but it was just really interesting that, on its own, it could really actually identify these hidden kind of lesions that we normally don't find.
So we definitely don't want to be getting angry emails from radiologists, but I do think a theme this past year is how good the models have gotten in particular indications for this kind of analysis of imaging. And I guess if we were to look at the year ahead, they'll probably just keep getting better. Is there any reason that it won't just be more and more and more of these?
I think that there's a lot of interest in images because for a human to be able to look at all of these images there's just so much information. There's so much attention to detail. And I think, AI can really look at all those images in massive proportions, right? So I think the model, in order for it to get better, is to be able to have more images, but to ensure that you have both a diversity of images in terms of either conditions, but also in terms of quality as well. That's how the model is going to get better, is feeding it similar to ChatGPT and these type of generative AI models. The more you kind of feed in, the more information that you give it, the more that it learns the different patterns. And that's not to say that, AI can't make mistakes, but it can hold a lot more storage and information and track those patterns, I think, more than singular kind of humans can in one go.
And I think we forget sometimes that even before language models, there was an awful lot of work on image analysis. And so in some ways, I always feel like some of these papers are kind of a preview of coming attractions where radiology gets there first or imaging gets there first, and then the rest of medicine is sort of catching up because we don't have the same head start. but we'll see. Maybe this will be the year we start to catch up. Let me tell you about mine, or my first one is a very different kind of paper by Edelson and colleagues, and it's called Early Warning Scores with and Without Artificial Intelligence. It was published in JAMA Network Open in October. And, a lot of, I think, what we're going to talk about uses transformer models and generative AI. This is definitely a year of lots of large language models. This is different. This is old school predictive AI, right? So this is like put the features in, turn the crank, and get a prediction out. And with all the buzz around language models, it's easy to forget that, predictive models in a lot of ways are things we understand a lot better. They tend to be deterministic. We tend to have pretty good sense of how to evaluate them. We're not worried about them going rogue and, needing to be guardrailed and so forth. This was a study that looked at 3 proprietary AI early warning scores, so early warnings of clinical deterioration, and compared them to sort of simpler aggregated weighted scores to identify patients at high risk for deteriorating in the hospital. And it was done at Yale New Haven, and they looked retrospectively and then looked at additional cohorts. I think the reason that I liked this study is that it's really, you could argue it's a bake-off. And sometimes we don't like bake-offs, but it's a bake-off of sort of models that could be in production that people, in various times have been excited about. And I think it makes the point that we're going to see now, as the barrier to entry gets lower, as there are more and more and more of these, we really need more transparency. We need more independent benchmarking of these kinds of tools, because you look at them in the abstract and they all look great. They all look like they perform very well. But the real question is which ones perform best. So my hope is this year we'll see more of these kinds of studies, except not just running kind of retrospectively, but in production, right? That we'll start to see real randomized trials or other kinds of real world evidence saying, we have these models, here's how they might actually be useful in directing patient care. So that's why I picked this one.
So is Roy Perlis saying that he likes bake-offs now?
Well, I think the thing that, for folks who are coming to this, from a clinical perspective, in the computer science world, there's lots and lots of these kind of machine learning papers where you take 10 different things and you say, which one is best? And you have the table and some of the p-values are bolded. And, I think that can be valuable, especially if you're trying to establish our new model is better than something that came before. But I think as we move towards clinical application, it's not so much how did these 10 models do, it's is this new model better than the old ones? And one of the things that has driven me crazy is the extent to which predictive models in medicine have been like that movie Groundhog Day, where it's always the first model. It's always like, hey, great, we found a model. And you're like, but what about all the other ones? So I hope this year we'll see more of this kind of work, but in production, in randomized trials, going prospectively. But I think this is a good start.
Yeah, I see your point. So you want this basically in kind of the idea would be like an RCT kind of trial and testing these models going forward.
I think so. There are still a lot of models where we need to understand how they work retrospectively, but medicine is practiced prospectively. So I think that's how we need to start studying the best of these.
So my next paper is also a large language model. It's the year of large language models. It was by Ray in JAMA Pediatrics, actually. And it was looking at evaluating ChatGPT-4 to see if it could translate personalized pediatric patient instructions into Spanish. And they compared it to professional human translators. And so basically they used real instructions from clinical visits, and they compared the translations, and they showed that, ChatGPT performed just as well. And they made actually fewer mistranslation errors, and reviewers actually preferred the AI output. And so this is another area that I think is going to be very promising for large language models, right? Is this idea of translation. I think in general, communication is so important. And it also is a huge barrier and it does exacerbate disparities. And so if we can start to really use these models and if they become very effective, the high volume of translation, and then hopefully, the next step is what I hope to see in the future is kind of the type of, even audio type of translation and the immediate type of translation that you can have with, the patient and the clinician so that you can communicate more effectively and provide that better care. I think that that's what I would like to see. And that's what I liked about this study is actually translating these real instructions and seeing that ChatGPT could do it actually professionally and really well. Because language is challenging, especially when you're translating clinical instructions. And so I like to see that. And I would like to see in the future, hopefully measuring patient outcomes and the difference that it makes in terms of not just kind of communications, but overall how that actually improves the care.
When I think back to my time as an intern back in the dark ages with my 4 words of medical Spanish and, 3 words of Haitian Creole, I got an awfully long way with those words. But I think now, patients deserve to be able to communicate in the language they feel most comfortable with. And some of the work in real-time translation is truly remarkable. So this may be the year or couple of years where we start to see that really percolate into clinical practice. I was going to say, I think we've seen a lot of articles about large language models that are either large language models do amazing things or large language models do terrible things, right? There's one genre of like, we used it and it can predict X. Isn't that amazing? And then there's another one, we asked it to do this thing and it was terrible at it. But I think your paper is a good reminder that there's another whole category, which is they just do some useful things that probably go way beyond medicine, but will be really useful in a problem in medicine we still haven't really been able to solve, which is, getting an interpreter at 2 a.m. who speaks the right language at the right time.
Yeah, exactly.
So, Yulin, there's also been this undercurrent in a lot of the work that we see of, how soon will docs actually feel the impact of these new tools, right? There's a world of difference between this worked retrospectively or this worked in this very artificial situation. And people are starting to think about, what is this really going to look like in medicine? I mean, you already showed us a paper where it can do an awful lot of what a radiologist might traditionally do looking at a particular kind of image. So the next paper that I picked is one from almost a year or so ago, where we saw one of the first reports from the field that's probably going to be among those most impacted early by AI, which is radiology. It's another paper that was in JAMA Network Open by Liu and colleagues about artificial intelligence and radiologist burnout. And this was cross-sectional study. It was basically a survey that asked a bunch of radiologists how often they use AI and gave them a burnout questionnaire. Lots of limitations to this study, not randomized, lots of response biases. It's not, when I say not randomized, not really a random sample. Still, what it shows is those who were most engaged with AI, those who were finding that they used it most often at work, were also the ones most likely to report greater levels of burnout. And by the way, the survey was actually done close to 200 years ago in AI years, which is end and middle of 2023, right? So, AI was really just starting to percolate into clinical practice, but I think it's notable that people were complaining of more burnout with AI use rather than less. So the idea that this is going to improve productivity may be true, but its impact on physicians' quality of life, I would say, remains to be seen and probably tells us something about how important context is going to be and how important it's going to be to make sure we integrate this in a way that actually makes life better for physicians or actually makes patient care better, but also without having costs on the clinician side. So that's why I brought this one in, because it's one of the first to really look at burnout among docs using AI.
I think that's really interesting because I think what I've heard and what I've read is something similar happened with the EHR, right? The electronic health records, right? And that burnout that clinicians really started to feel using it. And that had a lot of potential and it is wonderful for research, you know. I love it for research, but the actual use of it is taking away from that kind of patient clinician interaction and relationship. And so what's different now is what I like about the study that you picked is that we're doing that study now before AI has been integrated so that we are prepared and we understand that this could actually lead to more burnout versus before with EHR, it only took so much longer for people to really realize that that was what was going to happen. And so by the time that happened, it had already been in, and there was so much that clinicians had to do. And I'm also really happy that you picked a survey study because I picked a survey study as well. So I'm going to talk about my next study because I think it's actually a perfect kind of transition. And for the audience, we did not look at each other's picks. So this is actually quite good. This study was by Reese and it was in JAMA Network Open. And it was actually looking at public perceptions of physicians who use artificial intelligence. So looking at from the other end, looking at the public's perspective on how they view physicians who say they use artificial intelligence for administrative or diagnostic or therapeutic tasks. And so this was a survey of about, 1,300 US adults. And basically they compared identical ads that did not mention AI and then ones that did mention AI. And the ones that did mention AI, they found that it produced significant drops in perceived competence, trustworthiness, empathy, and willingness to book an appointment. So I think that this is a really good study to look at because just in general right now, I think there's been a lack of trust just in overall public health and in medicine. And I think we're at the point where it's really important that we communicate with the public, right? And so even that kind of modest drop in trust where we're kind of on that borderline right now could really reduce patient uptake. And so I think this study really shows that when we integrate AI, which is happening, we really need to discuss this with the public, with patients, and really be communicative as to how and why AI supports care, also ensuring them that the clinician still remains responsible. And so, I just love this study because my research area is on looking at public attitudes, and we're not rational creatures, right? We are emotional. And so it's really important to understand how people are feeling towards AI and how we can not just build the public's trust, but also kind of regain it with the integration of AI.
But don't you think if you'd done a survey like that 20 years ago about if your doctor's using the electronic health record and recording notes while you're in your visit, would that have made you trust your doc more or less? I'm sort of wondering how much of this is just new technology makes me anxious. Because what I think about is when I was training one day, I was working with a primary care doc and we saw a rash that he didn't recognize. And in front of the patient, he pulled out the dermatology textbook and started flipping through looking for something that looked like the rash. And at the time I thought, I can't believe that he's showing that he doesn't know enough dermatology and he has to look it up. The patient's never going to come back. And in reality, I think the patient appreciated that he was saying, I don't know the answer to this, but I know where to look to find it. So I wonder if there's a communication issue here where communicating how docs use AI is the important part. Because in the same way that you don't really get to choose if you see a doc who uses electronic health records, I suspect over these next few years, it's not really going to be a choice to see somebody who doesn't use AI.
Yeah, I mean, I like all of your points. I mean, I think I'll answer them all with the first, being about the EHR. I don't think I knew what it was or what it would be. It just sounded like it was going to be just recording my data. And I think we weren't aware of the issues that people have now about privacy. And so it was more, there's a cusp, right? Of you don't know enough. And so you're not scared. And then you know too much and you kind of become scared. And then you know too much and you probably just don't care again at that point. So everything's like a normal curve. But I think the difference with AI is they're at the point where there's too much kind of unknown and there hasn't been probably enough communication. So I think you're correct that it is about ultimately communication. So when you describe the physician who was looking up the dermatology, I think that, if I think about it in that scenario, I think about, okay, well, there's humility in that, and that you are trying to learn more information to provide me better care. Versus if it's a black box and you walk away and you say, just give me a second, and you feel that the doctor doesn't know what they're doing and looking something up, or is hidden away in the corner hiding and pretending not to search for information. So I think it's about the communication. I think it's about the transparency that is really important. And I agree with you, we're not going to live in a world where clinicians don't use AI, but I think that's the point too, is communicating with them what they're doing and making sure that they trust what is happening and they know what's going on. That's the whole transparency portion of it.
Yeah, I like that you introduced the concept of trust, because this was a problem that preceded AI in medicine and in science. But I do think, AI is either an opportunity to address some of the trust problems we have or exacerbate them. And probably there's still a chance for it to go either way.
Well, what I find really interesting too, and I know you're going to talk about another study too, is I always find it interesting how we don't seem to have an issue with new types of technology though, right? Like if you go for like an MRI scan and it's a new machine, or you go for an ocular exam, and they're taking new photographs of your eye, or they're going deeper.
I like when they do that.
Yes, I love when they do that, right? It's a new machine. You're like, oh, this is so cool. You have this puffball that goes into your eye. You have no idea what it is. And, it produces this image and you love it. And yet with AI, I have similar fears. So, what is it about AI? Is it about, again, this black box that you're not actually seeing the tool? You're not seeing a robot. You're not seeing the results, I think is one of those things. They're not telling you what is happening or what you're going to get out of it. You get to see an image. A lot of the time they explain it to you. You get the x-rays. So maybe it's that. Maybe it's this idea of it's just too abstract. It's too unknown for people to feel comfortable around it.
Yeah, I don't know. I think it's going to boil down to education, but you are right. The abstraction makes it hard. I mean, just in this conversation, we've talked about such different kinds of AI that we could spend an hour explaining one of them. I want to jump to kind of straight up the middle, like, gee whiz, kind of amazing that we can do this. Kind of splashy paper in JAMA recently that describes a pipeline for interpreting cardiac echo. It was called Complete AI-Enabled Echocardiography Interpretation, or PAN-ECHO. It was in JAMA Cardiology, I think. And basically, it's a pipeline for making measurements from transthoracic echo and then labeling the images. And I mean, this is kind of amazing when you think about it, because it's not, we're going to take an image and we're going to extract one feature from it. We're going to take a series of images and we're going to extract all the data that we can from it. So I picked this one because there are lots of different ways to apply AI, but this is the sort of thing that if 10 or 15 years ago you said we'd be able to do it, I suspect there would have been a lot of skepticism. And yet now it's built, it's being validated prospectively. I think these kinds of tools are going to be workhorses in medicine, especially for imaging. So I picked it just because I thought it was a really lovely illustration of what image-based AI can do. And I picked it, by the way, even though I can't say echocardiography. So I knew that it would not be easy to talk about this paper. It's a really neat paper.
Can you describe the methods a little bit more? Like what type of image analysis that they did?
They're using neural nets, the kind of bread and butter deep learning approaches to parsing images. But I think what makes it impressive is the scale at which they're doing it and the number of features that they're extracting. And the fact that they developed this using a historical set of images and then did prospective validation. So that was really, again, sort of a tour de force.
Yeah, I always say too, again, like we just talked about, is just how many features that can be extracted now and how much information it can absorb, I think is quite remarkable. This is not what this podcast is about, but I'm very worried about the energy consumption. But that's stay tuned. That's another podcast coming up, I guess.
Well, but if we're talking about things you're worried about, because we were talking about this coming year, so you said energy consumption, but a few minutes ago, you also said robots. So it's not 2027 yet, but how worried are you that this stuff is going to drive us off a cliff? How much do you worry about AI more generally and its danger to public health?
I think,
not to put you on the spot, but
no, I'm pretty worried, to be honest with you. I think, again, it's being in the field and so much that, you see how the sausage is made. And I do worry about more of this kind of cognitive complacency, more on a societal level, that we're using AI to think for us, right? And the same kind of fears that we have where the AI model is only as good as the data that we inputted, and we have to make sure the data is really good, it's very diverse, and it's updated. That's the other thing. It has to constantly be updated, similarly in, how in medicine where, we're using potentially practices that were based on studies that were 20, 30 years ago, right? That needs to be updated with new patient information, new patient demographics. And so I do worry that we will, both in terms of the AI drift, as I mentioned, but also this idea that because we're going to find AI so easy to use, right? Like Sam Altman said, is that, nobody born in the next generation is going to be smarter than AI, right? And that's because AI is going to do the work for them. So then where does the kind of human intuition and the creativity and the innovation come from? Because, in using these tools, you definitely know that they cannot create new knowledge, right? They can synthesize, but a lot of the time they're regurgitating a lot of information. And so if we lose that ability to think for ourselves, then we lose our ability to innovate and push things forward.
Cognitive complacency. I like it. I mean, I don't like it, but I absolutely see what you're worried about. So before we get too depressed, what's your next paper of interest?
You know what? Actually, it's by one of our AI editors, Romain Baraccio, and it's the Ovis reinforcement learning study. So this is where I do think AI can be very useful, right? Because this study is very clinically relevant. So because septic shock treatment usually starts with norepinephrine, and there's still this debate with clinicians on when to add vasopressin, right? And so what this study did is they used reinforcement learning, which is a type of AI that learns by trial and error to kind of optimize those decisions over time. And in this case, they use, real patient data, right? And so they train the model on, our favorite electronic health record system of more than 14,000 patients across, 200 hospitals. And so what they ended up finding was that the model actually suggested that vasopressin should be actually started earlier and at a lower norepinephrine dose and at lower sequential organ failure assessment scores than what we typically see in practice. And so when that is integrated into kind of real world care, patients can have lower hospital in mortality. And so I think it's just really important that we have these studies that are kind of using, real world information to kind of update clinical practice guidelines. And so again, having AI be able to analyze, thousands of ICU cases to identify the best time to start vasopressin in septic shock, this can kind of help guide this hour by hour treatment decisions where, these kind of traditional trials or these static guidelines, like I mentioned before, can potentially fall short. So that's where I think AI can really, again, be able to use kind of this real-time kind of information to be able to ensure guidelines are up to date.
It's an interesting exercise to say, of everything that's been written on AI and health so far, how much of it actually changes practice. There's a lot of, if validated, this could, but I think very little so far that is changing practice. Hopefully this year that changes and we start to see real impact. Right now, I'd say there's a lot of real potential, but I liked that. I liked Romaine's paper a lot too. So I'm glad you picked that one. My next one, across the JAMA network, we published a lot of commentaries this year. I think a lot of people have a lot to say about AI and have had, not unlike us, and have said interesting things. But given the pace of the field, it's so hard, right? Because I think some of the things we were debating a year ago seem less pressing now. And some of the things we barely talked about a year ago, like, for example, ambient scribes, really weren't being discussed that much until about a year ago. And now all of a sudden they're everywhere. So I mostly steered clear of commentaries, but I picked one from my list from Ken Mandel, who's at Boston Children's. And it acknowledges something that I think makes a lot of us anxious. So it's a paper called How AI Could Reshape Healthcare, Rise in Direct-to-Consumer Models. And it was in JAMA not long ago. And it basically outlines the fact that there is a groundswell of AI efforts that are aimed not specifically at clinical care, but at direct-to-consumer products. And those can be wearables or chatbots or other things that go direct to the consumer and arguably provide something that is at least relevant for healthcare. And I think it's a nice balanced commentary that acknowledges that there's real potential here to disrupt and to address a lot of the problems in healthcare. Could improve access, for example, but that there are also some huge challenges ahead in terms of regulation, because there are lots and lots of ways that these kinds of applications may kind of end up outside of traditional means of regulation, like FDA, for example. And there's also real risk of bias and sort of differences in access, because when you go to direct to consumer, on the one hand, it's easier for people to access, but it's only easier for them to access if they have the resources. So I really liked that it just lays out this point that I am fairly sure we'll be hearing more and more and more about over the years to come, which is providing care or things relevant to care kind of outside of the traditional system. So I liked that viewpoint a lot.
And so when you say outside of the system, how do you visualize it being outside of the system? Like, what would you like to see?
Well, I think the question is, we will be giving people a lot more information than they're accustomed to getting about their health status. Take cardiology, right? So you can get an EKG at home. You can get, very recent data saying you can get your blood pressure, or at least an estimate of whether you have hypertension at home. So we're giving people unprecedented amounts of information. It's also easier than ever to access that kind of information. I mean, obviously before you might just Google it, but now you might go to use AI to get answers. So it's more information about your own health and more information about what to do about your own health. On balance, those are great things in general. That sort of democratizes healthcare. On the other hand, in some cases, the net effect, I think, is just to frighten people or to make them think that they have to take responsibility for their care completely outside the system. It's a little like when people would come in years ago with printouts from the web, right? Like, well, this says I should be on X. And I think there was a generation of docs who were really offended by that. right? And then there was a generation that appreciated that people were that engaged in their healthcare and got good at saying, well, yes, you will see that on the internet. Here's my concern about that. So I think AI is in the same place now. People will come in with more information than ever, and we'll need to be better at helping them make sense of that information. So anyway, I thought he makes a lot of good points. No one has a solution, but at least we can start thinking about how we're going to get there.
Well, you see a lot of stories of patients entering like their own electronic health records in, right? And asking for a diagnosis. So I think that's already kind of begun. And, there's a lot of success, quote, stories that have been out there. But there are a lot of also issues again with AI. And again, that potential actually trust in AI that you might have that leads you to potentially not make good decisions, for your health. So I think we're going to have to figure that out. It's just whether or not we can figure it out fast enough in terms of what to be able to do.
So what's your next article?
I'm going to end on our call for papers, Roy, that just came out, led by Alvin Liu and some of our AI editors, and wanted to talk to you about what we're looking for, what we want to see, and what the future of AI and medicine is going to kind of bring. And I know that you had first kind of touched on it too about wanting these kind of prospective clinical trials, right? And this kind of even longitudinal follow up and measuring like real patient outcomes. But what else? What are we looking for?
So I think the real answer is we don't know yet, but we know that there are areas where there are real gaps in our evidence base. So you talked about real world evidence, and that means we tend to reach for randomized trials. And certainly we love to see randomized trials, but we also recognize there are other ways to establish effectiveness. So I think trials embedded in electronic health records, I think, as you said, more longitudinal data about how these models perform in real world deployments. We really have to understand what is the impact of deploying predictive models or certain kinds of generative AI or really any of these interventions. What is the impact in the real world? I think there's a lot going on that we didn't get a chance to touch on today in relation to things that are sort of adjacent to healthcare or enablers of healthcare, like ambient scribes, like models that hospitals use to determine utilization. And I think none of those are likely to be regulated in traditional ways, but will have a massive impact on how we take care of people. So I think another thing we're interested in seeing is what's the public health impact of this stuff? So beyond individual patient level data, although that's really important, is what does it mean when we start to deploy this stuff at scale? And something we haven't seen enough of is what are the consequences of AI use more generally in terms of health, in terms of mental health, but also other aspects of health. I think what we are hoping in the coming year is that we're shifting more and more to empirical studies. Not that we don't want to hear interesting opinions, but let's go out and understand what these things are doing. I actually have one more paper that, I think is a nice illustration of something that I never would have thought of. So it doesn't even make it into a request for submissions or a call for submissions. It's a paper that was in JAMA Dermatology not long ago by Yang and colleagues called Artificial Intelligence-Enabled Wearable Devices and Nocturnal Scratch Reduction in Atopic Dermatitis. So this isn't making predictions. It's not translating anything. It's actually an AI-enabled wearable device that detects when patients with atopic dermatitis are scratching in their sleep. Small study, 10 patients, almost as many patients as authors, but really cool. It detects when they're scratching, and then there's an efferent arm that vibrates when they do that to wake them up just enough so they stop scratching, and shows a detectable benefit, because there's a crossover design in getting patients to scratch less. So this kind of, to me, the reason I end with this one is kind of pulls it all together, right? It's potentially a consumer device, or at least something outside of traditional healthcare. The AI is embedded in, you don't really think of it as something that needs to be especially intelligent, except it's doing the signal processing to figure out when someone's scratching. And it delivers an intervention on the spot to try to change that behavior. So I'd love to see more of that kind of work in the next few years, where AI just sort of becomes part of the devices around us and not only detects the signal, but potentially helps us manage it as well.
Yeah, I think that there's so many applications for AI that be extremely interesting to do studies on. I think one area is kind of AI in medical education, for instance, right? Is how can we train, the next generation of clinicians using AI? Can AI be a tool to have conversations or mock patient experiences, for instance, and to give that type of feedback? So I know there's several projects that are ongoing that is studying that. So I would like to see that as well. I think that it is happening, but I think there's a lot of AI being used probably for health policy, in that realm, making decisions using AI or communicating decisions, using AI and kind of seeing that effect on, like, again, a population level. I don't know if they will release that information, but I think it'd be very interesting to see the effect of that because I think it's being done. And so I think for public policy, it'll be really interesting. And then I think going back to kind of the multimodal aspect is it's so difficult doing studies with so many different types of mediums. So I think what I would like to see is combining kind of imaging, clinical notes, and like lab data to be able to see better insights than like a single modality type of models, I think would be really fascinating, and seeing if we can kind of combine that together to be able to get, a full picture of the patient, right? That kind of encompasses all of those different modalities.
So on that note, I think provided the robots don't get us this year, we will come back next year and we can see if we got any of this stuff right or not, and if we got the kinds of submissions that we are calling for. I want to thank my co-host, Dr. Hswen. And to our listeners, if you want to read more about any of these articles, you can find links to them in the episode description. As a reminder, for the latest and greatest AI content across the JAMA network, be sure to check out JAMA Plus AI at jamaai.org. To follow this and other JAMA Network podcasts, visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for joining us, and we'll see you next time.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.